Thanks for joining in time.
Good evening,
And before
everyone.
time.
Good evening.
Good evening, everyone. We are starting with the Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Good evening,
Good
everyone.
afternoon, everyone. So, I welcome you all. Why is there?
मैम आपकी ऑडियो ब्रेक हो रही है, एक बार डिस्कनेक्ट करके कनेक्ट.
Disconnect?
नहीं, हाँ अब मेरे को इंग्लिश देखो.
मैम आपने शायद 2 जगह से ज्वाइन किया है.
नहीं, डिवाइस तो एक ही लग रहा है.
ओके हाँ
मैम एक बार
करा तो एक से ही है.
आप एक ही से है. यस मैम.
हाँ मैम, ये स्टार्ट मैम.
Hello. Still there is.
मैम आपका 2 ऑडियो आ रहा है. एक सेकंड, हम एक म्यूट कर रहे हैं. एक सेकंड, एक म्यूट कर दें मैम. अब बोलिए आप.
Hello.
हाँ अब ठीक.
Am I audible?
यस मैम, यस मैम.
Okay. So, I welcome you all on this second Tuesday for the CME. This time we are organizing this CME of Haryana chapter of NIGF along with the Haryana chapter of SOFC because we thought still there is some going on. So, we thought to take this very important topic, NDVA, jaundice and vaginal hysterectomy, for discussion this day. Hello.
यस मैम, यू आर ऑडिबल मैम. आप 2 डिवाइस से कनेक्टेड है, तो एक डिवाइस को मैंने वेटिंग रूम में डाल दिया. अब ऑडियो क्लियर है.
कंटिन्यू रही है.
Okay, and I am visible also?
यस मैम, यस मैम.
Okay, but I am not able to see. Chalo, oh, anyway, so at the outset, Dr. Ragini has joined.
Yes.
I think.
Yes.
Namaskar, Dr. Ragini.
Hello.
At the outset, we would like to seek the blessings from Dr. Sharda Jain, ma'am. I have talked to her. She won't be able to join, but her blessings are always with us. Then I would like to invite Dr. Ragini for her guidance. She is the guiding force behind all of us, and she is our dynamic president. We are lucky to have her in our state. So she's always there to encourage us. So Dr. Ragini, ma'am, please give your blessings.
Thank you, Meenakshi. And it's not a blessing. I'm not so big that I will give a blessing. But I welcome you all, specifically being it is a Haryana NIGF. So as a part of the Haryana also, and as a central person, I welcome you all in the today's webinar. And it was totally executed by Dr. Meenakshi and Dr. Savita, such a beautiful way. And here we have some big names in the field of the vaginal surgery, like Dr. Sonal Batla is also with us. So friends, I just want to say, as the president today, it is your own association. Any association, any institution is always bigger than a person. And it will be only grow if it is a person faceless association. Today I am there, tomorrow you are there. So consider your own association, grow it, come to annual conference to Chandigarh, join it and make a difference in the managing committee meeting, how to run the NIGF in future. So we have a strong association whom we can leave like a legacy to our coming our successor. Thank you so much. Over to you, Dr. Savita.
Thank you, Dr. Ragini. So without wasting much time, I would like to invite Dr. Ankita. She's our assistant professor in our institute, a young dynamic girl, and she has just joined NIGF also. So Dr. Ankita will be conducting the ceremony. Dr. Ankita, please, you are there?
Yes, ma'am. Good evening to one and all present here. Am I audible, ma'am?
Yes, ma'am.
Yes.
Yes, you are audible.
To one and all. Yes, ma'am. Good evening to one and all present, ma'am. On behalf of NIGF Haryana chapter, I, Dr. Ankita Yadav, working as assistant professor at PGIMS Rohtak, and I'm honored to welcome you all to today's CME on the session NDVH. Coming to session number 1, our first scientific session is with the title NDVH in the scarred pelvis after the previous cesarean, a surgical video session. To conduct this session, we are privileged to have our esteemed chairperson. Our chairpersons are Dr. Professor Pushpa Daya ma'am. Ma'am is head of the department at PGIMS Rohtak, a renowned clinician whose expertise and leadership continue to guide and inspire us all. We welcome you, ma'am. Our next chairperson is Dr. Sonal Batla ma'am. Ma'am is director and head of the department Obs and Gynae Yatharth Super Speciality Hospital, Delhi, and a distinguished leader in
Very warm welcome to today's
general surgery with numerous national and international awards and honors to her credit. We welcome you, ma'am. Our third chairperson is Dr. Kiran. Ma'am is renowned private practitioner at Faridabad. Ma'am is secretary NIGF chapter Haryana, and ma'am is president of Faridabad Obs and Gynae Society. I respectfully invite our esteemed chairperson to kindly take over the proceeding. It is my privilege to introduce our speaker, Dr. Elizabeth Jacob ma'am, an accomplished gynecologic surgeon and respected expert in vaginal surgery from Apollo Atlas Hospital, Kochi. Today, ma'am will be sharing her expertise on managing adhesions and navigating the challenges of NDVH in scarred pelvis through surgical video series. Over to you, ma'am.
Can I invite the first speaker?
Yes, ma'am.
So I take this opportunity to invite Dr. Elizabeth Jacob. She's a very good friend, though she's the Secretary General of Society of Vaginal Surgeons of India, a gentle soul who is now running a training program in vaginal surgery along with Dr. Paili. She is the member of the Foxy Vaginal Surgery Committee also, and has many accolades to her credit. Dr. Elizabeth Jacob, please. She'll be speaking on adhesions, anatomy, and acumen, NDVH in scarred pelvis after 3 previous cesarean section, a surgical video series. Dr. Elizabeth Jacob, please.
A very, very warm good evening to one and all. It's an absolute pleasure, honor, and privilege to be here with the NIGF chapter, and also partnering with SOPSI Haryana chapter. And I'm floored to hear these words from Sonal ma'am. Yes, have been through this last 2 years. I've had great association through SOPSI with so many great leaders, and Sonal ma'am is definitely one of them. And thank you, Savita ma'am, and the entire team from NIGS, all the respected seniors, for giving me this opportunity. With the permission of the chair, I'll just get my presentation to be shared. Hope it's visible to all.
Yes, ma'am.
Okay, shall I proceed?
Yes, doctor. Yes, ma'am.
Okay.
Warm welcome to you.
Thank you, ma'am. Thank you so much. As vaginal surgeons and as gynecologists, the vaginal route is definitely our, our own route, our best route for all kinds of gynecological surgeries. But when it comes to previous cesarean, there is always a hesitancy in our mind regarding what would be the ideal route to perform the hysterectomy. The main 3 A's that I would be trying to go through in the next 20 minutes will be the adhesions, the anatomy, and the acumen, which will guide us through this scarred pelvis. I think I'm not able to move to my next slide. Okay. When we think about previous cesarean, it's always the first A that is the biggest roadblock to us is the adhesions, the scarred vesicocervical space, and the dense adhesions in the midline. The second A is the is the anatomy, which is totally different from what we have already learned as far as the normal anatomy, where the bladder and where the cervix starts and the uterovesical space. The normal plane does not exist in most of those cases. And the final surgical acumen comes when we learn to utilize the lateral surgical window to actually navigate through the scarred uterus through sharp dissection. So we'll start with the first video. And of course, we need to remember that the safest surgeon, whenever we think about a non-descent for a previous 1, 2, or 3 cesarean is considered, is not the fastest one, but of course, one who respects the altered anatomy and is willing to change the path early, depending on the findings that we find along the way. So I'll start with this video. So the first and foremost part, whenever we encounter a case of previous cesarean, is to assess it through an examination under anesthesia and preoperatively to be sure that is there a ventrofixation of the uterus. As gynecologists, we are all aware about the dimpling sign and Shade's cervicofundal sign, wherein a traction on the cervix, if there is a dimpling on the scar, which should definitely put you on caution that there could be additions which could be a deterrent to completing it vaginally. So that is the first and foremost step that we need to do whenever we are planning for a previous cesarean through the vaginal route. The second important thing is to assess all the parameters preoperatively under anesthesia. So there are 2 examinations preoperatively, one in your OP room and other one in the in your OT setup. So in that, when you come, just a minute, okay, yeah. So in that, when we think about the preoperative parameters that are of most importance is the mobility of the vaginal mucosa and the descent with the valcellum. So these 2 important things are another important things that we need to assess before we proceed vaginally. Once we have finished the assessment, we put in our first incision. We always use the vasopressin injection. I could initially to give us a bloodless and a clean field. Once we have done that, we go as much as possible through the vesicle to gain access into the vesicocervical space. In previous 3 cesarean or previous 2 or more cesareans, our concern is not to push into the vesicocervical space, which we know is already scarred. So move till the limit that you can actually see. Wherever you can see, stop your dissection there and proceed posteriorly to open the virgin area, which is the posterior pouch. So once you have opened the posterior pouch, you can confidently proceed with clamping, cutting, and ligating your pedicles. So the most important pearl that we need to remember is there is no rush to open the anterior pouch in previous 2 and more cesareans. Always go only up to the limit that you can actually visualize and cut the additions, and then proceed posteriorly to open the posterior pouch and start clamping, cutting, and transfixing your pedicles. So once you have done that, now we proceed to cutting, transfixing, and the pedicles, both the Meccan rods and the uterosacral pedicles. Here we are going step by step. So as we do one side, then we move to the other side. And then once we cut the Meccan rods uterosacral complex, you can see that you have a further descent down. And you have a better vision to actually see where you need to actually dissect further. We are all aware that the bladder can be densely adherent both in the area where the previous scar was and also even higher up in some cases, as we will see in our next video. So the scar is most adherent medially in the middle 3/5, and it is mostly free in the lateral 1/5. That is a dictum that we have been taught, and that is a dictum that we need to follow in all cases of previous cesarean. So having cut, clamped, and transfixed the uterosacral Meccan rods complex, we can see that there is further descent for us to visualize, and small snips we give in order to gain access into that lateral free space. That is our idea. So with that bit of it, wherever we are able to remove the, adherent part in the lateral space, we will be able to easily gain access into that free virgin area and then find our way into the middle where the adhesions are very dense and thick and which should be definitely cut. The most important part as far as previous cesarean or previous 3 cesareans or previous 2 cesareans, whichever way it is concerned, is that no blunt dissection. Once we have reached that space, now you can see that we can clearly see the adhesions between the bladder and the cervix. And that is the scarred vesicocervical space that we need to dissect to gain access into the UV pouch. So here, we are trying to utilize this lateral space. You can see as we are giving small snips with the tip of the scissors pointed downwards onto the cervix or to the uterus, we are able to get that virgin space, which is where the bladder is lying free, despite it being very densely adherent in the midline. So there, we put in our next clamp. We have almost reached the uterines without opening the UV pouch. So that is one important point that I want to highlight, that in cases of previous cesarean, let the emphasis not be on trying to open it and only then ligating the pedicles. We can gradually go laterally where we have already separated the bladder and try to ligate the uterines and even beyond. Sometimes we have even reached up to the conval structures without actually entering the POD. So that is possible, but we have to ensure that your assistant is your good friend who is holding the anterior retractor so that the bladder is kept well away from your clamps. Now, gradually, you can see that the lateral window is opening up. We have almost opened up into the UV fold. There is hardly a thin membranous part left through which we can actually open and gain access into the utrovesical pouch of peritoneum. So even in our previous 3 cesarean, we can easily gain access if we remain in the right plane and follow the principles of sharp dissection and keeping the bladder away. Now, this is the the broad ligament free space that we always vouch for in cases of previous cesarean, and gradually we have actually entered into that space and we are opening up the pouch of the utrovesical pouch gradually to finally complete our hysterectomy part. Now, once you have opened the pouch, then it's like anybody's game to just complete it by clamping, cutting, and ligating the pedicles, and finally closing the vault. But I think after every hysterectomy, in which it is a case of a previous cesarean, the most reassuring part will be to see a clear urine draining at the end of a procedure, and that's what we'll also be looking at. So now, having opened the UV fold of pouch, now so you can see that we have almost completed the uterine when we opened the pouch. So that is a very, very important point, that as beginners or in our time or race against time, we often get ourselves pushed to opening the pouch before we actually want to get the bladder off. So that is the mistake that often pushes us into getting into a bladder injury. So once we have actually kept the bladder away under the anterior retractor and gone in the right plane, we can safely ligate even the entire uterine pedicles without actually entering into the UV fold. So this is the most important part that we need to remember. And then finally, we can reach the fundal structures easily. Usually in previous 3 cesareans and previous 2 cesareans and more, usually the cervix is elongated and the cervix is longer than the body of the uterus, especially if it is if we are doing it for a AUBO or a AUBA often. So in that kind, now we have reached the fundal structures, and it's just a matter of time before we can reach the fundal structures on the other side and complete our hysterectomy, and then finally close the vault. All cases of our hysterectomies, we all perform opportunistic salpingectomy. So for our patients too, we do the opportunistic salpingectomy along with the hysterectomy part. So the lateral window approach should be the dictum in cases of previous cesarean. It may be the game changer or the biggest risk saver for us whenever we have a case of previous 2 or more cesarean sections, and always A clear draining urine is the most reassuring sign for every gynecologist who is attempting to perform the same. And of course, we need to remember that in all cases of previous 2 or more cesareans, your speed doesn't matter. Going forward in the right plane is all that matters. To reinforce that in previous cesarean, the central 3/5 is adherent, while the lateral 1/5 on either side is free. It is up to us to utilize the surgical window, familiarize ourselves to this space in order to perform a safe surgery. Always use sharp dissection. Anterior retractor, like I said, your assistant who is guarding the anterior retractor should be your friend, should be your junior whom you have not scolded the prior day, and should be safeguarding the bladder safely for you. Always use the lateral window approach. You can sound the bladder in between if you're in doubt. At times, if the uterus is small, we can go for the retrograde identification. Whenever in doubt, fill with saline or methylene blue to demarcate the borders. And whenever you're using electrosurgery, which is quite common nowadays, use it with extreme caution, especially when the bladder is nearby. If at all a bladder injury occurs, it is extremely important that we have an immediate recognition of the bladder injury and do a good intraop repair with a high degree of vigilance and acumen. Now, some cases may be much beyond the routine size of the uterus. Even a large fibroid can be there, or multiple fibroids, enlarging the size of the uterus to 16 to 18 week size. In those cases with previous cesarean, again, the basic dictum remains the same: to proceed with opening the posterior pouch like we did in the initial case, and then clamping, cutting, and transfixing the pedicle and utilizing the lateral window. But along with that, it might be also important that even before we actually complete the uterine ligation, we might have to start off with our debulking. So in those cases, we can inject vasopressin and do our debulking posteriorly, which is the safe area for us compared to anteriorly, where we might not have actually entered into the anterior pouch, and we may not know exactly where the bladder is still lying adherent. So those are those cases in which we might require to proceed posteriorly and do our debulking from the posterior aspect of the uterus, trying to remove as much as the myomas as possible, which are accessible to us, or do a coring or a morcellation or a wedge resection, depending upon each case which is presenting to us, and then debulk the uterus so that you can see much more ahead on the anterior surface and actually do the dissection however it is possible. Now, in this, in the initial one, it was an adenomyotic uterus, and we were able to open the pouch and then go ahead with the debulking. But in the second case, as you would see ahead, that because of the size of the uterus, we couldn't proceed anteriorly to opening the pouch. And so we proceeded posteriorly to remove the myomas before we actually open the anterior pouch. So in such cases, and you are not able to proceed further, not able to see, do not be in a hurry to open the pouch anteriorly. Instead, go posteriorly, keep your retractor as the guard, and go ahead and do your debulking as you would have done. So the posterior area would be your easy friend and guide to complete the complete the debulking part, and to reduce the size of the uterus for us to proceed further. So here, this was a large large fibroid, intramural fibroid, and around 6 or 7 centimeters, which was actually debulked initially before we actually gained access into the anterior pouch. So these are some of the cases in which we might have to alter our path as we come closer and closer to the case. So in this, once the debulking is completed, then your anterior vision becomes much better. You are able to see more clearly, and then you can proceed with your, opening up the pouch anteriorly. So these are the cases in which you might need to proceed posteriorly first. Now, yes. So the golden rule is don't push, always cut. Stay extremely close to the cervix. Use sharp dissection like we said before. And if the plane is unsafe, pivot early. Do the debulking first, or you think about whether you need to convert, or you never persist in the wrong plane for a long time and then end up in injury. So the safe mnemonic should always be remembered. Stay as close to the uterus, give adequate traction, find the right plane, and elevate the bladder. Now, this is another interesting case that despite all our precautions and even our prejudgment under anesthesia, we can land up in some unexpected findings in cases of previous cesarean. This was the case of previous 3 cesarean for which case of adenomyosis for which it was planned. You can see that the cervix was just hardly visible. But anyways, the initial part of the surgery went on as we would otherwise also do, incising the cervicovesical space after injecting the vasopressin. And due to lack of time, I'll just move ahead with the initial part, which we've already seen in the other videos. And as we proceeded further, the scarred area, you can see how much scarred it is. So cutting sharply and very carefully and gently in trying to enter trying to cut as much as the scarred vesicocervical space would allow us to. And then moving posteriorly to opening the posterior pouch. You can see we are opening the posterior pouch now. And then clamping, cutting, and transfixing the pedicles as we did prior, and sharp, careful dissection as much as possible to remove the adhesions. But almost even as much as we could reach up to the uterines were covered. We were clamping, cutting the uterine vessels now. And still the descent or even the, was not adequately attained despite almost reaching through the lateral window into the lateral space. So that was a concern, but still we proceeded with caution and almost completing the uterines on either side. Almost we felt that, we had entered the UV fold, the pouch of the uterovesical fold of peritoneum laterally, but still there was something in the midline that was preventing this from descending down. It was still not able to descend further. And anyway, gradually persisted laterally till the point that, we realized that, further descent is not at all happening despite we reaching this point. So you can see that laterally the uterines is almost completed, but still the main part of the uterus was still remaining high and not descending at all. The lateral window approach, like in all cases, was being followed. And then we found that we had an adhesion band actually, which was preventing the uterus from descending. So this adhesion band was what was preventing the uterus from descending down further. Now, actually, you can see, 1 minute. Yeah. So you can see that laterally it looked like we had entered into the UV fold, but still the uterus was not at all descending down. And despite, checking once, twice, this band was really something that was difficult to, identify even with all our preoperative measures. Finally, under vision, whatever vision that we could gain access into, and keeping the retractor to keep the bladder away, the adhesion band was cut, clamped, and ligated close to the uterus, and then we finally gained access. So this was the adhesion band, which was actually preventing the uterus from descending despite opening up into the UV fold of peritoneum. So sometimes in previous 3 cesareans, we can land up in such cases where we might not be able to identify it preoperatively. So you might have to change your track or change your thinking at the time of the surgery to actually keep the possibility of addition bands in mind, and always cut only under vision and as close to the uterus as possible. You can include a bit of myometrium in it. It is okay, but and safeguard your bladder. So once the addition band was removed, then the rest of the procedure was easy. We could actually gain access into the pouch of Douglas, into the UV fold of peritoneum, and then complete the hysterectomy as we would otherwise. So then finally, we could finally put in the retractor properly and then do the debulking and then gain access. So this is one important point that I would like to highlight and say that whenever we get the idea that there is more bleeding, there is some dense resistance, and you're seeing some fat or muscle fibers, think that there is something beyond that plane, and it might not be the right plane that we are traversing through. And always have the idea that in the right plane, there will be minimal bleeding, there'll be loose areolar tissue, and the bladder would move easily. So in such conditions, you might need to actually change your track. Now, there can be other cases, especially in previous cesarean, when there can be a pinhole kind of cervix, which it may not be amenable to your routine valcellum. In those conditions, you can use your slender instrumentations. We use the Alice, which is normally used for our circular Spilicer's modification. And with the help of such slender instruments, you might be able to complete the surgery in such cases. So you might, all these is just to emphasize that in different situations, you might have to innovate yourself differently to the requirement of the patient and accordingly proceed. But it is always important to know when you need to convert. So if the additions are not budging despite all your efforts, if there is torrential hemorrhage and you're not able to control it, if you suspect there is visceral injury and you're not sure that you'll be able to tackle it vaginally, and if the access and size is not giving you a blind approach, those are times that you definitely need to think. And when it occurs, suspect when there is hematuria, and you can always fill with normal saline or methylene blue and never miss multiple sites of injury. Ureteric orifices stenting should always be kept in mind, and especially in extensive injuries. And then, of course, bladder repair is something that we all need to know. But in all such cases, never waste a good failure. Whenever we think that the conversion is a failure, it's not a failing one. It is actually a thinking surgeon who has done the right thing for her patient. So I end with the same A's which we started, the A1, which is the additions. So the bladder is definitely our enemy in previous cesarean. In every previous cesarean, it tends the bladder upwards and fuses it with denser fibrosis. So the natural cleavages are lost. The scar may be avascular, but it's unforgiving. So never use blunt finger sweeping tear. It actually tears the bladder, while the sharp controlled dissection makes it stay safe. And expect the worst additions and sometimes bands like what we notice that we might need to circumvent. Always remember sharp where it is scarred and slow where it is stuck. And blunt dissection is the commonest route to cystotomy in a scarred uterus. Our A2, which is the anatomy, always find the plane before you trust it. Use the lateral surgical window for safety. That is your safest route, road map for in all cases of previous cesarean. And when the anterior plane is hostile, open the posterior pouch and you can actually proceed with your debulking if at all you're required to, and it actually reorients you. And whenever the anatomy is wrong or confusing, use the metal catheter to actually understand where the bladder is. You can fill the bladder and also use the dye. And the A3, which is the most important, I think all our seniors, the learning from all our seniors has always been to have the right judgment around the knife, the correct patient selection, and assess again under anesthesia before you proceed. and counsel and consent for the possible laparoscopic or the laparotomy. The plan can change, but the consent should not be a surprise for the patient. We should always sequence deliberately. Take the uterosacral pedicles to win the descent before you can challenge the bladder, which would be quite higher up. And hold a threshold to convert when there is no plane, when the bleeding is so much you can't see, or blend the bladder, you are just not able to define mainstream. So our doubts are often traitors and make us lose the good we oft might win by fearing to attempt, said William Shakespeare. So choose wisely, operate calmly, and convert smartly. And I welcome you all on part of SOCSI. I think ma'am is here. Ma'am is the queen and the king and everything of the national conference. So we'll see you all in Delhi. And like ma'am said, the SOCSI Kerala chapter is running this vast program. So inviting you, all the juniors who are interested, to please contact. Thank you so much for the patient hearing.
This is a great session, highlighting the importance of hydrodissection, shades cervical space, and an important step that you should open the POD first in patients with previous cesarean section in order to achieve a little bit of descent so that you can dissect into the planes properly. And always use sharp dissection in patients with previous cesarean section. That will save you from any kind of catastrophe. So any comments from anybody? Dr. Ragini is here.
So Sonal, such a beautiful video. I just don't want to speak after this.
Thank
you.
I think it was fantastic, Dr. Jacob. And I congratulate you, Dr. Sonal, for taking this chapter of SOCSI North India so dynamically, and our own team, Savita, Meenakshi, you all make the program so interesting that it is really important for all of us to sit in the comfort of our home and look at the best, tips and tricks. So it was fantastic, Dr. Jacob.
Thank you, ma'am.
It was a visual treat.
It was a really brilliant presentation, Dr. Elijah. Brilliant.
Thank you, ma'am. Thank you so much. I'm truly.
And one thing I would say,
Yes,
that bladder does not, still, you can circumvent bladder, but the endometriosis, if the pouch is, occluded,
yes,
then your NDVH will have to be converted. So that is one thing, like we all know.
Ma'am, we'll have more tips and
Lateral
tricks
approach
on
is
it
the-
also, ma'am, sometime.
Sorry?
Lateral
We can
approach is
have
the
some
best.
tips on tricks on that also.
Yeah,
Like
definitely. You have to take a part 2.
So this lateral approach does wonders actually in case of NDVH, not only in the previous cesarean. Otherwise also very big size uterus is there. When we are able to open that is the thing. We have to open the pouch of Douglas first before, when we are not able to assess. Once you open the pouch of Douglas, always on the lateral side, both the uterus are very clearly visible, especially when the fibroid is in lower uterine segment or cervical fibroid. So we have to go by the lateral approach. And sometimes the McInrods are these uterosacrals are quite lower down when in case of NDVH you see. So we may have to take separately the uterosacrals and the McInrods lateral. So that is also one thing has to be done in these cases. So thank you, Dr. Elizabeth, for accepting our invitation.
Thank
and
you, ma'am.
we
It's an
became
honor.
wiser by your presentation.
Dr.
Thank you.
Kiran
Yes.
Chandna, you would like to
Excellent.
something?
Yes, ma'am. Videos were excellent and you have given the very good take-home messages for beautiful dissection and to avoid the complications. And the lateral window approach and the sharp dissection and filling the bladder with the methylene blue, opening from the posterior side. These were the messages. I think we are all thankful to you for giving us the very good messages. Thank you so much.
Thank you so much, ma'am.
Thank you, Dr. Savita and Dr. Meenakshi, for this session. And I again invite all of you to the National Conference of SOCSI. That is on 25th, 26th, and 27th of September. 25th will be the live surgical workshop, and 26th, 27th will be a video workshop. I invite posters, papers, and abstracts for case reports. I mean, you can all encourage your PGs to come and attend and present.
Thank you, Dr. Sonal. Thank you for joining us.
Thank you, ma'am.
Dr. Ankita?
Yes, ma'am. Thank you, Dr. Elizabeth Jacob, ma'am, for the excellent presentation and for sharing your valuable surgical expertise with us. I also thank our esteemed chairperson, Dr. Pushpa Daya, ma'am, Dr. Sohal Batla, ma'am, and Dr. Kiran, ma'am, for conducting this session so efficiently. We now proceed to session 2 on tips and tricks of NDVH. To chair this session, I am honored to invite our distinguished chairperson, Dr. Mitra Saxena, ma'am. Ma'am is renowned gynecologist, endoscopist, and director at Sri Ashwini Saxena Hospital, Rewari. Our next chairperson is Dr. Ruby Bhatia, ma'am. Ma'am is professor and head of department at MMIMSR, Bolana, Ambala. Ma'am is highly respected teacher, clinician, and researcher. Our next chairperson is Dr. Anita Sharma, ma'am. Ma'am is a senior consultant obstetrician and president, Gurgaon Obs and Gynae Society. May I request the esteemed chairperson to kindly take over the session. Our next speaker needs no introduction. Dr. Ragiri Agarwal, ma'am. Ma'am is president of NIGF and a distinguished gynecologist and an authority in minimally invasive gynecological surgery. We welcome you, ma'am.
So I think Dr. Ragini, everybody knows. Let's start off with the scientific session. And I'm sure it's very interesting to know that every speaker has their own volume of experience and they bring their own learnings into the lecture that they are going to deliver. Over to you, Ragini, to take us through tips and tricks of NDVH.
Thank you so much, Mitra, and thank you, Dr. Savita and Dr. Meenakshi, for giving me this opportunity to speak on a topic which is day by day is vanishing. And after seeing the videos of Dr. Elizabeth Jacob, this is not for the beginners, but the main tip and tricks always same when we talk about the NDVH. So with blessing of God and the gratitude to one and all, my exact topic is the first NDVH, a beginner's roadmap to safe vaginal hysterectomy. It is not for the experts, not for the master. And this particular topic, when it was given to me by Dr. Savita, I went back when I did my first NDVH. I was not learned this particular operation during my preparation.
इतनी गर्मी में कहाँ घूम रहे हो? Swimming pool.
अरे यार मत करो swimming. मत करो swimming.
जी मैम.
So actually, when I came in practice and I came to the conclusion that without doing the vaginal operations, you are not a gynecologist. Abdominal hysterectomy, yes, it's good, but anybody can do, but the vaginal is our forte and we should learn. So here I'm going to share some tips which I always keep in mind and started doing the NDVH. So when we talk about the NDVH, we all know by the definition, when there's no prolapse and we are doing a vaginal hysterectomy, it is NDVH. And here it is little difficult because the support are normal, there's no prolapse, and it is really sometimes very difficult to catch hold and take down this uterus. Since 1940, it is the vaginal hysterectomy is there, and when the laparoscopy is increased somewhere in 1990-92 in India, I still remember at that time Dr. Kurtzem and Dr. Bruha used to come and we used to go to Bombay to learn the laparoscopy. So first hysterectomy, LAVH, at that time no TLH is there. So they did the first LAVH in a very small laddu size uterus in 4 hours or 6 hours, too much time. Then another Bombay gynecologist came and almost more than 20 weeks uterus, maybe 24-week uterus, and it did in the 45 minutes NDVH for that uterus, Dr. Pai Gungar. So this is the beauty, how you learn, how you want to apply. No doubt, NDVH is the route if we think specifically the smaller uterus. When we talk about the minimally invasive surgery, in laparoscope also we are making the incision. And when we do the NDVH, it's really a no scar surgery. It's a natural hole which from where we can do, but it needs lots of practice, lots of expertise. And I think every gynecologist should master, at least for the smaller uterus, we should go vaginally. As Dr. Elizabeth has said, that bladder. So if there's no scar, where am I? Will I injure bladder, ureter? It is something is always in our mind. This fear pushes us towards the more of the laparoscopy. But here the most important factor is your anatomy. You understand your anatomy. Where is your bladder? Where is the ureter? How you have to go, and the planes. So revisit your anatomy books, understand, work on the simulator, and where's the pedicles, how you are going to tie the pedicles. They should be always very, very towards the uterus. You have not go to the lateral. And as I'm very comfortable to do the clampless surgery, so in that I don't put even the any angles or so I go inside the Mackenrod ligament by a Leahy's. So if there's not even the space, we can do it. So pedicles, instrument, how you are going to apply these things are very, very important. And please don't ever hesitate to have an initial stage or some senior colleague with you who can take you to the road of the mastery. So easy beginner cases are the multiparous women, mobile uterus. Not even jump to the initially the first NDVH on the 12-week size. Good descent, no major previous surgery or no surgery, and benign disease. Very important to do a per vaginal examination properly when patient is on your table without before saying that whether what route you are going to take. And whenever you say take these cases for the NDVH, always talk about the conversion also. It is no shame. If there's a fixed uterus, large fibroid, endometriosis, severe adhesion, distorted anatomy, prior multiple surgery, it is not for a beginner at all. So you have to orient with the pelvic anatomy. My tip to each and every beginner is close your eyes and sit and make this diagram in your mind. Think how you are going to incide. When you are doing a vaginal delivery, it's my own tip, it is not written anywhere because we all do lots and lots of delivery. After delivery, when you are doing the episiotomy, this is the time you palpate on the side. See everything. And this is the time when you learn the real pelvic anatomy when you are doing a deliveries, because everyone, when we are the PGA student, the most common thing which we get is a delivery. So learn one thing, ureter always run in the lateral pelvic wall. Uterine artery crosses over the ureter. Cardinal ligaments contains uterine vessels and uterosacral ligaments provides posterior support. The moment you start dissecting, the ureter moves away when pedicles are taken close to the uterus. So the first and foremost thing after assessing that it is a free uterus is when you start taking the pedicles, always stay close to the uterus. You will be always safe. Now, small medial pedicles protect the ureter and ensure a safe NDVH. Coming to the layers. We have a vaginal mucosa, then we have a vesico-vaginal fascia, then we have a bladder and the anterior pouch. And on the back side, we have a posterior vaginal wall, pouch of the Douglas, and the deeper tissue. Do not cut tissues, and you have to open the space. My tip to beginner is always and always go from the posterior space. It is so easy if you go by the posterior space. So you have to protect the bladder ureter. You have to, if you are in a good plane, there's a less bleeding, and you have to maintain orientation, ensures safe and easy progression. So this is the diagram which shows how we have to go. Understand the anatomy, open the correct vascular place, identify and respect the space, stay close to uterus for safety. Never force on any tissue. So now coming to the how to go about the operation. First, we have to do the circumcision incision. Many surgeons, they advise to go with the hydrodissection. I have never done it. I never do it. I only do go directly. But I usually go by the posterior pouch. Specifically, it is a smaller uterus. The hysterectomy and my time become very easy. Then we have to go with the uterosacral cardinal ligaments. Remember, here there are normal ligaments. They are taut, they are thick. Many a time they are younger women. No laxity is there. Sometimes you have to take these ligaments in two parts also. Then when it little bit come down, it is very clear by Dr. Elizabeth videos that when it come down, you have to go very slowly. Cut, pull, cut, pull, cut, pull. And then when you go to the uterine artery, it is very necessary to secure it. If you are not properly securing it, and at this time, you cannot catch it again. So secure uterine artery properly, and gradually with the nick by nick, with the smaller nick, you can go above. Remember one point here, that the distance between the uterine artery and the cervix is almost fixed. What is real problem? Your uterus size. They might be much bigger. So broad ligament up to going to the carnival level is a bigger, and you may need to apply above uterine, not one, but 2 or 3 clamps also. So after carnal pedicle, you have taken, remove the uterus and do the vault closure. So this is just a pictorial thing, because sorry to say, I don't have any video. Recently, I did only TLH. No patient is ready for NDVH. So I told also Dr. Savita the same thing. I don't have any video. And before this 2020, we are not in way to have the videos with us. I'm very clear. So, but the posterior pouch entry, this is the golden choice for the beginners. And then you come for the anterior pouch entry. It is always easy. And for the carnal pedicles, when you clamp and cut one side, you can push the uterus from one side, and the other side you take down your other side of the carnal ligament. You can very easily catch and do. So, in nutshell, stay close to cervix, use sharp dissection, separate spleen safely, identify shiny bladder pains, push bladder upward very gently. No blind pushing, no excess traction. If there's too much of the bleeding, that means you are not in the right plane. Too high lateral, injury to the bladder wall. Too low, injury to the cervix, and there's a bleeding. So now, why we go with the small and the safe pedicle? It is very clear. If we go with the small pedicles, ureter at risk injury is really not there. Now how we are going to remove it. Bisection is one of the most easy thing, but always remember, when you are bisecting the uterus, always save your bladder. As Dr. Elizabeth has very clearly told you, your retractor is your friend whom you have never scolded. Then second thing, when you catch hold these cervix, sometime your valsalum slips. Either you have a cat paw instrument or apply 2 long alleys to hold the cervix. And you can take out the myoma, debulk it, you can marcellate, although marcellation we don't do easily. Usually we do the coring or the bisection, and myoma is there. We remove the myomas whenever the possibility. Conversion is a wisdom, not a failure. Dr. Elizabeth has also told you, even she's talking about the 3 initial phase. You are a good surgeon if you protect your patient. Don't hesitate. Your ego is nothing. You are saving your patient is the biggest thing, and taking a senior with you is never going to make you someone less. So whenever you are fixed with the anatomy, uncontrolled bleeding, dense adhesion, maybe sometime you are calculated wrong or bladder is not identified, think early, act wisely, save lives. So golden rule is easy case, respect anatomy, stay close, small pedicle, open posterior pouch first, never panic, ask for help early, good judgment today, safe injury always. So tips for the young gynecologists, please learn your anatomy, orient your anatomy, tissue plane identification, mastery of the pelvic clamp, suggested learning milestones, assisting at least 15-20 NDVH cases. One thing I can say, where today everybody is doing a TLH. You can, your TLH cases, convert in the LAVH and learn, because today it's very difficult to learn the NDVH if in your institution, your seniors are not doing NDVH. Hands-on cadaveric or the simulation-based workshop, they are coming in a big way. Transition to moderate complexity case to mentorship. Mentorship is really matters. Go and learn, have the courses. Vaginal route has no camera, only judgment, but that judgment can be trained step by step. Use a checklist, standardize your process, reduce missed steps, improves team communication. And post-operatively, pre-operatively, case selection, consent, bladder catheterization, pelvic examination, and your own trolley. Sometime that bladder catheter, metal bladder catheter, if it is missing on your trolley, it will create a problem. So always see your own trolley. Don't leave on your juniors, or I can say your OT assistants. But the most of us who are doing the single hand practice in our nursing homes, we are dependent on our OT assistant, on our sisters. So pre-op examination, the anesthesia again do, assess mobility and descent, and use hydrodissection for the scarred bladder, or you can learn initially step also debulking, ensure secure pedicle and vault closure, and practice on the simulation. Never and never go with a blind anterior colpotomy and skipping pre-op pelvic assessment. Don't directly jump for the operations and over-reliance on the retractor without good lighting. Learning what not to do is something more powerful than knowing what to do. These pitfalls are common and preventable. So these are my references. Friends, we are vaginal surgeons. Although laparoscopic and the abdominal routes often overshadow, but it is a time-tested approach with excellent outcomes, especially when appropriately selected. And confidence comes from anatomy, not the speed. I think this is the last slide of Dr. Elizabeth also. So speed does not matter. At the end, what matters, what you are delivering. Thank you so much for your patient hearing.
That was a very nice presentation and lovely colorful plates. So even if you didn't provide a video, but your graphics were very, very engaging and very nice. I think it's endorsing, live videos we've seen with Jacob, and yours is very nice summary. I can only say one thing is that complications actually kill the confidence, but planning in time and having a good experienced surgeon by your side, then you can, that is a very, very smooth way to improve your own operating capacity. So capacity building and holding. Yeah.
Thank you, Mitra. Dr. Ruby, unmute कर लीजिए. Unmute. Yes, I have taken the help of the AI. You should make the AI your slave. Then only it can work properly for you. Dr. Bhatia, make yourself unmute.
Dr. Ragini, एक talk करनी पड़ेगी how to make such good presentation with AI.
मेहनत करनी पड़ती है बहुत ज्यादा.
बहुत सुंदर.
Thank you. Dr. Bhatia, Dr. Ruby, unmute कर लो. उनको सुनाई नहीं पड़ रहा है. चलो.
Yes. Good, Madam. Namaskar, ma'am. It was a beautiful, excellent lecture. No doubt, mentor's lecture has always to be excellent. A few tips. In my every OT, I keep one vaginal hysterectomy or an NDVH. I would say NDVH now is hallmark of gynecology. And if a 12-week size AUB or adenomyosis comes and somebody asks, you will do robotic, you will do laparoscopic or abdominal, the answer should be NDVH. The reasons we all know. Some tips are because there is no descent in this. So always for 1 to 2 minutes, we should squeeze the uterosacral ligaments. When we squeeze the uterosacral ligaments for 1 to 2 minutes, the uterine descent occurs automatically. Please try it in the next case. Second, we, with every step, pull the uterus down and push the bladder up. And once we apply the uterosacral ligaments, make them, keep them long and keep on pulling them down. That causes a lot of descent and makes the further steps very better and easier. And to prevent any ureteric injury, we should always remain medial to the pedicle we have applied on the uterosacral ligament. And as we pull down the uterosacral ligament pedicle, in fact, that is the only pedicle which can be kept with long threads. No other pedicle we have to catch hold. With that, ureter also goes down. So these few steps, if we take in mind, the NDVH for the beginner becomes easier. And for opening the pouch, we always need a very good trick that it should, from the cervix, at least go 2.5 centimeter down. Don't incise just near the cervix posteriorly. It should be an inverted V, and the depth of that from the distance from the cervix should be minimum 2.5 centimeters. Because in my PG and SRship, I've seen the seniors struggling to open the pouch, and then pouch automatically opens, ma'am. I have beautiful videos and I will share, ma'am.
Good evening, ma'am. Dr. Ragini, your presentation and slides were very neat and they seemed antique. And I think topic should have been NDVH made easy. So they were so beautiful. And one point I want to make over here is that when we learned vaginal, we started with third-degree prolapse. We learned it from the prolapsed uterus. But I think teaching should change now, and the teaching should start with the first-degree descent or NDVH for mild laxity uterus for the students. That's easier to learn, and then we should shift on to the prolapsed uterus. What is your comment on this, ma'am?
प्रोफेसर्स बताएंगे, हमारे पास तो अभी स्टूडेंट हैं.
Yeah, actually,
Yes,
I agree
I
with you,
agree
Dr.
with
Anita.
Dr. Anita. Initially,
Ji,
when we
ma'am.
started this so many years ago, we always used to just before planning the patient for the NDVH, we used to see how much it can be pulled down or just there's no
Yes, it
mobility.
was our criteria to do vaginal regal.
But I
Introitus was
think,
lax or not. So
but
introitus
I
is
think
lax and
prolapse.
slight, it is not prolapse, I'm not talking prolapse. Lax introitus and somewhat means your own pulling, somewhat it comes, not the prolapse. So that is the beginners they can do and small size uterus. In the beginning, they
Small
should
size
go for
uterus.
No,
That
but
is
Dr. Anita, I think
not the
first the residents should do the and vaginal hysterectomy for prolapse uterus.
Yeah.
Then once they
That is,
become confident opening the
yeah.
anterior pouch and everything, then they can start NDVH. And
No,
then all the
actually,
points that Dr. Savita said.
Meenakshi, I think, let me tell you that if you have a third degree UV prolapse with cysto recto, it's more difficult to go in the correct planes and all that and open the pouches. If you do a small uterus with laxity and do NDVH, the planes are much clearer and easier actually. We have learned it that way, but I think what I would say NDVH with little bit of laxity and first degree
yes,
descent,
multiparous
small
uterus.
uterus is the ideal case.
Yes,
Because
the
then you can
beginners,
open the
uterus.
pouches in
good
one
thing
go.
about the good thing about it is that the general surgeons are not doing the NDVH.
Yes,
It is
ma'am.
Okay,
the
हमारे
domain
यहाँ
of
तो
the
general surgeon
gynecologist only.
NDVH भी कर रहे हैं, don't
Yes,
worry.
Years to come, they will
Ran.
start.
This is
You should graduate.
So,
Elizabeth ma'am
the
has,
vaginal is our signature route, ma'am, and I think it should remain strong in our hands as gynecologists.
but
Ragini, ma'am, it was beautiful presentation, lovely slides, and your experience was oozing in your talk. I really loved it. Thank you.
yeah, ma'am. We must graduate. Initially, we must do prolapse cases so that
yeah.
we learn the proper anatomy.
Of
Then
course,
we
profidentia can be difficult.
normal
Profidentia can
size
be
and
difficult.
NDVH.
But third degree prolapse, second degree prolapse, I think we should start with that only.
Yes.
Otherwise, opening the pouches are not easy in NDVH. They are high up. In prolapse, pouches are low down, and it is just simply
Also, second
visible in
degree
front
middle
of the eyes.
compartment defect would be the ideal case to start.
Yeah.
So I had worked with Sheila Mehra ma'am. She was a very good she has been a very good laparoscopic surgeon, but she used to do lovely NDVH also.
Dr. Pushpa is there. Dr. Ankita, is
So
Dr.
she
Pushpa
used
there?
to ask me, you should have a very good assistant when you are doing NDVH. That is one very important tool. So she used to ask me, Anita, नाश्ता करके आई हो, बड़ा सा uterus दिया है,
assistant's hard work which makes it do.
Yes,
It's assistant's hard work which is required.
Very good
And we
assistance
must
is
take the
required.
subpubic angle also, ma'am. The subpubic angle should not be very acute. Then it's not possible to do anything.
Very true, Dr. Ruby.
रोशन जी, लोग ये एडमिट होना चाह रहे हैं, प्लीज थोड़ा सा एक्टिव रहिए, आप सोइए मत.
I would like to add, Dr. Ragini.
Yes, Dr.
Excellent talk. And we are from the NDVH era. If you remember, about 20 years ago, Agra में इतनी NDVH live workshops होती थी, and every stall used to have a set of instruments for NDVH.
Yes.
And we used those 4 instruments: a flat, heavy speculum, which is not the SIN speculum, single-handed speculum, which gives a nice pressure, and one anterior vaginal wall retractor, cat's paw, and 2 clamps. Two nice
long
clamps. And the set used to be come for about 20K, and then lovely workshops where the uterus would be out in 15 minutes, and the patient goes home next day because she's completely fine, not even small scars of lap. So along with expertise, a good set of instruments, good clamps, and although in those days we were just doing it with Vicryl, we were putting sutures, but nowadays I'm doing it with my monopolar cautery only. I don't even use that bipolar set which comes with harmonic. You have amazing clamps also, and those who want to start learning, there are very nice lighted speculums which are available so that you can see the tissue very clearly.
And if you are a beginner and if you don't have a lighted speculum, the regular light of hysteroscopy that can also be used to nicely see inside where you have to clamp. So it's an amazing surgery, less post-op complications and faster than lap hysterectomy recovery. I do TLH regularly, maybe for up to 24 weeks uterus, but still this is a golden surgery with good instruments. All of us should have an expert hand to do NDVH, and we must promote
We
amongst
should never forget to do vault suspension. When we
Ma'am,
do
I
NDVH,
think there is time
it is
constraint. We should.
mandatory to do vault suspension with the uterosacral ligament fixation to prevent further vault prolapse.
So it's such a nice topic, but I think some time constraint is there, Dr. Ankita.
Yes.
So really,
Thank
it
you,
was
Dr. Ragini Agarwal, ma'am, for the practical and insightful tips. My sincere thanks to our respected chairperson for their valuable guidance. Now we move to our next session. That is the final session for today on the topic complications of NDVH, prevention and treatment. To moderate this important panel discussion on complication of NDVH, prevention and treatment, I warmly welcome and invite our esteemed moderators, Dr. Meenakshi Chauhan ma'am. Ma'am needs no introduction. Ma'am is senior professor and unit head in the Department of Obs and Gynae, PGIMS Rohtak. Along with ma'am, we have Dr. Rupa Malik ma'am. Ma'am is professor at PGIMS Rohtak. May I now extend a warm welcome to our distinguished panelists. Our panelists are Dr. Krishna Daya ma'am. Ma'am is professor and unit head at PGIMS Rohtak. Dr. Vani Malhotra ma'am. Ma'am is professor in the Department of Obs and Gynae, PGIMS Rohtak. Dr. Jyoti Malik ma'am. Ma'am is a distinguished gynecologist, academician, and medical superintendent at JJ Institute of Medical Science, Bahadurgarh. Dr. Anita Rajoria ma'am. Ma'am is president of Obs and Gynae Society and a fertility specialist. I now invite Dr. Aarti Luthra ma'am. Ma'am is an accomplished gynecologist, endoscopic surgeon, and infertility specialist from Dehradun. Our next panelist is Dr. Monica Dalal ma'am. Ma'am is professor in the Department of Obs and Gynae, PGIMS Rohtak. I welcome you all, ma'am. Now it is my privilege again to welcome our esteemed experts, Dr. Manju Puri ma'am. Ma'am is an eminent obstetrician and gynecologist from Lady Hardinge Medical College, New Delhi. Dr. Savita Singhal ma'am. Ma'am is a senior professor and unit head in the Department of Obs and Gynae, PGIMS Rohtak, and a highly respected clinician and academician. We are honored by your presence and look forward for learning from you, your vast expertise in the management and prevention of complications in NDVH. We welcome you all. Over to you, ma'am.
Welcome.
Yeah. Okay. So, good afternoon, everyone. We are myself, Dr. Meenakshi, and my colleague, Dr. Rupa. We will be taking a few questions. So, I invite Dr. Rupa to take the first case. And she's already mastered by this. So, a gynecologist was doing a non-descent vaginal hysterectomy in gynae and she, while retracting the bladder from anterior vagina and cervix, she could see pink smooth mucosa, and she has suspicion of injury to urinary bladder. So my first question is for Dr. Krishna. What are the risk factors for urinary bladder injury while we are doing a non-descent vaginal hysterectomy procedure?
Hello, am I audible? Good evening, everyone.
Yes. Dr. Krishna, you are audible.
So pre-operative assessment to rule out all the high-risk factors is most important. Like various high-risk factors are like previous cesarean deliveries, previous cesarean section. The number of cesarean as goes on increasing, the chances of addition that also goes on increasing. Any previous surgery, pelvic surgery, patient with adenomyosis, endometriosis, chronic PID, chronic tuberculosis, these patients are high risk, and especially the postmenopausal lady who are having cervix flush with the vault. They are also the high risk in them. Their chances of bladder injury are there. Then depending upon the size of the uterus, if the big size uterus, especially the multiple fibroids, because they distort the anatomy of the uterus. And cervical fibroid, broad ligament fibroid, these patients are also high-risk patients. Then certain technical points like mostly the injury occur when we are pushing the bladder, like giving the first incision on the at the cervicovaginal junction, and when we are pushing the bladder, that incision is not given properly. The retraction is not proper. Either the incision is too deep or it is too superficial, and the bleeding starts while we are pushing the bladder. And especially if we are doing the blunt dissection, then in cases of previous cesarean, the chances they are very high. So poor visibility, sometimes I don't say inexperienced surgeon, but sometimes it can happen with everyone. Bladder injuries, they're liable to happen sometimes.
So when plane is not the right, then the chances of bladder injury are high.
Yeah, working in the right plane is always important.
So what is the incidence of bladder injury during NDVH? Dr. Jyoti,
Dr.
please.
Jyoti is there? Dr. Jyoti? I think she's not there.
I think I can tell the answer if
Sure, sure.
yeah. So when we talk about abdominal hysterectomies, the incidence of bladder injury is quite low, around 0.5 to 1.5%. If we are attempting laparoscopic hysterectomy, it may rise up to around 2% in few studies. And regarding vaginal hysterectomy, it is again quite less, 0.6 to 1.8%. But when we perform NDVH, sometimes few have encountered the complications to be up to 3.6%. So, of course, radical hysterectomy is fraught with danger of much more complications because of the wider dissection we are doing. So, if we take overall the incidence of such complication of bladder injuries around 1 to 3% grossly. So, we have to be very, very careful.
Yeah, thank you so much. Actually, also the incidence depends on the type of surgery that we are doing. If there is a big cervical fibroid, broad ligament fibroid, if it is endometriosis, so basically it also depends on the causative factor for which we are doing the surgery. But I think basically it is maximum is around 0.1 to 3.5%, I think.
And it is more in NDVH than vaginal hysterectomy when we are doing it for prolapse.
Right.
So our next question is, are there any preventive strategies for prevention of urinary tract injury during NDVH? My question is for Dr. Vani Malhotra.
Yes, the preventive strategies for preventing the urinary tract injuries, I think the most common is when we start the NDVH. We should, when we panic in the initial part of the surgery, we will go on doing wrong things. सबसे पहले तो we should have confidence while doing NDVH. We should do proper pre-operative evaluation. We should empty the bladder, and if we have some difficulty, we can always use a metallic catheter to see the extent of the bladder. We were taught when we were PG students that always know the extent of the bladder with a metallic catheter. Then apply the incision over the cervix. So because the Foley's won't be able to accomplish this goal. So, and whenever there is a case of previous cesarean, so we should not attempt a blunt dissection in cases of the scarred tissues. Rather, we should go for sharp dissection because the blunt dissection can injure the bladder wall and weaken the bladder wall. We should stay as close as to the cervix and the uterus while doing the bladder dissection. And whenever anatomy is not clear, or we should never hesitate to convert it into laparotomy or laparoscopy if the anatomy is unclear, if there is a big fibroid, and if you are not able to clear the adhesions. So that way you can prevent the bladder injuries.
So of course, the lateral
lateral approach, yes.
Lateral approach is there.
Approach is the most important in cases of previous scarred uterus.
Yes. So next question is for Dr. Aarti. How will you recognize bladder injury intraoperatively?
First of all, thank you, Dr. Meenakshi, for organizing this wonderful webinar, which takes us to our old PG days when we were doing NDVH very regularly. I like it even now. So, bladder injury, I believe it starts from a thorough pre-op evaluation. Normally, I make sure if I'm taking a patient for NDVH, we have to do a nice bimanual examination to see the mobility of the tissue, and that also gives you some idea if there are big fibroids on the anterior wall of uterus, or if there are large broad ligament fibroids, then you have to be mentally prepared that the anatomy would be distorted. And then I always like to do one transvaginal ultrasound also myself pre-op to see that what is the contour of the uterus and how we are going to dissect the planes. And of course, when we are doing the surgery, being in the right planes and identifying the tissues, that is very, very important. We have to
Someone please mute yourself. Someone.
Yeah.
Poonam, please mute yourself. Poonam Gupta.
So rather than just waiting ki once we'll see the Foley's balloon, that means we have caused the bladder injury. When we start dissecting, we have to assess the depth of the incision, and we have to understand when we are going to through the vaginal mucosa, and then when we are reaching the cervix and we are pushing the bladder up. Of course, if we are in the wrong plane, there will be a lot of bleeding and the dissection will not be smooth. And if you have, because most of the time in these cases,
Roshan ji, please. So, Dr. Aarti, yeah.
Yeah. So,
please mute Poonam Gupta.
Please mute. Roshan ji, please mute Dr. Poonam.
Okay, ma'am. If there Foley's balloon, one should be prepared that the urinary leakage will not be there because the Foley's is there. So there is a drainage of urine continuously. So once we'll make the bladder, we may not always see the leakage. But of course, if we are in a different plane, and if you can see pink smooth bladder mucosa, because the look of the cervical mucosa and anterior wall of the uterus will be very different from the bladder mucosa. So we have to identify that site, and there can be hematuria in the Foley's. And sometimes what we do, if there is a rent, we can just put in a suture and leave it there to mark the rent, and we can complete the surgery, and then we can do a nice repair in 2 layers, and then we can check for the leak. But I think identifying the tissue, the kind of tissue, what is anterior wall of uterus, what is bladder mucosa, is the most important step. And of course, good instruments, adequate light can save us from injuring the bladder.
Is Dr. Manju there? Dr. Manju Puri, she's there?
Yes, I am there. Hanji,
Dr. Manju,
thank you, Meenakshi. I've
would like
been
to have your comments.
Yeah, I've been listening to all the talks and all your discussions. Yeah. So basically, to my mind, I think your first incision becomes very important.
Dr. Poonam Gupta, can you please mute yourself?
Yeah.
Thank you. Again, and Poonam ji, please mute yourself. Thank you.
All right. So, when you give the incision and wait for the upper, give it slowly and wait for the upper edge to retract. I think that gives you a clue, and always put a lot of traction onto the cervix. So that is one part. And the second part is, even if you've gone a little deep, if it starts bleeding, that means you've gone into the cervix. So that's another point. And in case, you are in doubt, if you hold the upper edge with Ellis forceps, you can see it attached, right? And then you can sharply cut those parts. And otherwise, the bladder will go with the upper flap. It will not have any attachment to the cervix. So I think these are the ways by which, I would suggest all the beginners to make sure that they don't People do have problem, and if you are not in the right plane, then please leave it there and continue with your hysterectomy. Open the pouch, and then you can apply the Macken rods. Keep doing it. Will open on the sides each time. So whenever you take a clamp, please make sure that the tip of the clamp is cleared, and ultimately it will open on its own. You don't have to worry. Yeah, that is my suggestion. Yeah, thank you.
Thank you, Dr. Manju. So next question is from Dr. Dr. Anita Rajoria. How
Yes,
will you
ma'am.
confirm the blood injury? We are suspecting that injury has occurred. Now, how will you confirm the injury to
Yeah.
blood?
So as Aarti has already highlighted, larger rents will show themselves. Either folies will become visible. The problem is when the rents are small and we are suspecting, then either we can do a retrograde filling of bladder. Methylene blue dye may be used. It should be autoclaved and diluted, and it should be used. And if there is any leakage from the bladder side, then of course it itself suggests that it is a rent. Or you can confirm by intraoperative cystoscopy if you have. Even a small hysteroscope can help you if you do not have cystoscope for that matter. But as ma'am has already highlighted, Manju, don't stop doing your hysterectomy. Proceed on to your further steps and just leave it there. Put a stay suture so that you know where was the rent initially, and then you can continue with the procedure and further do the repair at the end.
I would like to share one incident as we are talking about opening the anterior pouch. So there was one patient and we could not open the anterior pouch. There was only fibrous tissue coming up, and laterally we had reached till uterine. So then of course I decided to open the posterior pouch, put my finger, but still my finger was not going beyond the fundus in the anterior pouch at all. So we decided to put in the scope because we had taken a lot of time. Posterior pouch was open, but my finger was not reaching beyond fundus. And without any history of previous C-section or previous laparotomy, this patient had a ventrifixed uterus. And the uterus was anteriorly completely plastered to the anterior abdominal wall. So I was so happy that I decided to put in the scope and then do the dissection rather than I would have, been trying for much longer time. So sometimes if we are just not able to open the pouch, once in a while it can be a ventrifixed uterus. So don't hesitate in putting in the scope if you don't easily reach.
Yeah. So one sign for that will be that when you are doing examination under general anesthesia while you are starting and you are trying to find out how much descent is there, if so much of ventrifixation is there, when you pull onto the cervix, you will find some, retraction of abdominal wall, especially in large uteri. So that is
no had any scar. This patient only had
I'm just saying that in such cases, then it was such a ventrifix UTI. So that sign could have been, elicitable in few of the cases, especially with large uteri. Not obviously with normal size you can't because it's a pelvic organ then. But if their uteri are large and there is no history of previous surgery, but still when you pull it from below and you find there is retraction of anterior abdomen, there is something wrong there. So that things.
राम थोड़ी सी खा ले राम कुर्सी पे बैठ जा
Please ask this Roshan to mute everybody.
नहीं आ रहा
Meenakshi, please ask Roshan to mute Dr. Kiran and all those who are doing OPD.
Okay, ma'am.
Yes, ma'am. We can go on.
अभी मीनाक्षी को म्यूट कर दिया क्या?
We can continue. Suppose a bladder injury occurs, how should it be managed? Will you repair the bladder first or complete surgery, Dr. Krishna Daya?
First of all, when the bladder injury occurs, when we are doing surgeries, the complications, they are bound to happen. So first and foremost thing is don't get panic. And first thing is we try to avoid
Smita
bladder
Gupta,
injury.
please unmute yourself. Lots of disturbance is there. Dr. Smita Gupta.
मजे चल रहे हैं but
Mr. Roshan, why don't you be attentive? Please mute people who are making noise.
And maybe Roshan can switch off the video for a lot of audience also, I think. Then people will not be distracted. It'll be a nice gesture, I
I
think.
know you have to be attentive. We are being disturbed.
Dr. Krishna, continue.
Yes. So first thing is that don't get panic, and that management that depends upon what is the size of injury, site of injury, and at what time it has happened, whether it has happened from the very beginning or it is in the end, diagnosed at the end, occurred in the beginning, but sometimes it is diagnosed late and diagnosed in the end. So that depends upon the site and the type of the injury. Whether to repair it first or whether to repair it last, there is no hard and fast rule. That depends upon the surgeon. Some surgeons prefer that they will do the surgery first and then the repair. Or some, if this is a small rent, you can repair first and then go ahead with the surgery. So repair is to be done in 2 layers, and it should be no tension free, and watertight closure should be there. And at the end, we should do the methylene blue test so that there is no leak. And mostly the injuries, they are occurring at the dome or the posterior wall, and that can be repaired vaginally. But for medical legal purpose, sometimes if we are not confident enough that we can repair the bladder injury, we should take the help of the urologist. And if the urologist, mostly they are not, they will not do vaginally. They will do from the per abdomen route. And especially if the injuries, they are large, trigon is involved, ureteric orifice is close to the injury site, or ureteric injury is suspected, then the abdominal route is always better, because technically it is difficult to go through the vaginal route. I think I have answered.
Thank you, Dr. Krishna. Yes, you have answered very elaborately. So, but the post-operative care is very important. So, I will request Dr. Monica to tell us about when the bladder injury has occurred, we have done a repair, and how will you do a post-operative care of this patient? Dr. Monica is there?
Yes, ma'am. Yes, ma'am. I'm there. Am I audible, ma'am?
Yes.
Hello?
Yes, Monica, you are audible.
Yes, ma'am. When we have done the bladder repair in the post-operative period, our main aim is to keep the bladder decompressed. Because if there's a full bladder, it will stress the suture line and it can lead to repair failure. So our main aim is to continuously catheterize the patient and keep the Foley's catheter for around 7 to 10 days in the normal repair. And for complex injury, we can keep the catheter for 14 days. And we should frequently check the catheter for any kinking, twisting, or any blockages there. So continuous drainage is the main goal, and strictly monitor for the urine output, especially in first 24 hours. Watch for hematuria in the first 24 to 48-hour. Hematuria is a common thing, but if it later on there is hematuria, then we have to further investigate the cause of hematuria and keep the rule out any infection is there and administer broad spectrum antibiotics.
So, Dr. Vani, next question is for you. What is the injury in which per-operatively?
So if the injury is per-operatively, so the patient can present with hematuria. Patient can have paralytic ileus because of urinary leakage. There can be history. There can be she can have bouts of fever and paralytic ileus, and if the ureters are involved, can present with loin pain. So best will be that we identify the injury there itself and repair at the primary surgery. But if patient presents to you later with these signs and symptoms, the urinary tract injury should be suspected, and we should reevaluate the patient with dye test, cystoscopy, take the help of urologist, or we can go for CT urography to know the leak, the area of leakage.
Dr. Meenakshi, I think she has
Savita, can I add my little comment?
Yes, sure.
I think we must convey this message to all that it is not a problem to make a mistake. I mean, bladder injury can happen at the first start when you give the first incision. If the dome is, if the bladder is, we have some cystocele and you miss and you incise the dome, or it can be when you're trying to push the bladder up at the region of trigone lower uterine segment. So bladder can be injured. So one should not be afraid of that, but one should be very mindful that there is no hematuria which is persisting. Little bit we are expecting even in cesarean bladder पे pressure है ये वो, but we should be very mindful that we should not miss an injury. It's best to do all the confirmatory tests on table. Suppose we are in doubt, do a cystoscopy, do a leak test, put dye, you will be able to see the leak. So don't and of course document it well.
One more thing I have learned is
Yes.
that they are no more doing suprapubic drainage of bladder injuries now, because it looks very gory and it is very uncomfortable to the patient. Even larger bladder ends, when staged properly, they can be drained urethral by Foley's catheterization. There is no need for suprapubic drainage.
Actually, Dr. Anita, if
urologists in our part are still doing the day before yesterday one placenta.
the recent because of the recent this thing, they say that please avoid it, and if you have any doubt about your repair, they can just put another drain in the abdomen rather than doing suprapubic. So it depends what your urologist is saying, of course, but nowadays they say that they are avoiding suprapubic drainage.
Our
They
repair
should ensure that your catheter never gets blocked. That is very
Dr. Anita, am I audible?
Yes, ma'am, you are audible.
Yeah, actually, Dr. Anita, if it is a sharp cut, see, like Dr. Mitra has said, just the dome of the bladder is chopped off. Then you can just do the repair. You might not put a suprapubic catheter. But if it is ragged, say if it was adherent to the previous scar, then I think it is a better option to put a because we have also repaired. I have taken out bladder stones while doing vaginal hysterectomy. I have taken out bladder stones. We have simply cut the bladder, taken out the bladder stone, and did a bladder repair. We never put a SPC. But if it is a ragged type of, I think Dr. Savita will also agree with me.
Very true.
What are your expert comments?
I
See,
think
we have
if
to avoid a VVF. So how good a repair of bladder you can do after mobilizing the bladder is the key. So we do this or we do that. We just make sure that the repair is not compromised at any time. So I think that should be the final message.
Catheter should be draining. You have to tell your residents that ensure that every 2 hours they have to monitor that the urine output is.
Already Dr. Monica has told us very nicely. So I think let us take the second case because time is running short. So the surgeon.
Meenakshi, can I make two small
the
comments?
principle is that we should never miss the bladder injury.
Yes, Dr.
And if it is you're not that well experienced, always call the urologist. When it is up to the urologist, if he feels that it is a posterior part near the trigone, so they may manage accordingly. And sometimes they may go for this suprapubic cystosis.
So two small comments. One is that we should always try to put in a silicone catheter. That is always better. Whenever we have to leave a longer duration catheter. So whenever you have these injuries, please do that. And the second is that it is always a good idea to have a urometer attached so that every hour the urometer can be emptied and you don't have to empty the bladder, the bag over and over again. The third point is that, these patients don't need antibiotics for all the time where you leave the catheter in. Although these would need catheter not more than all these acute injuries would not need it for more than 7 to 10 days. But there is no need to keep them on antibiotics. You can always change their pH on weekly basis. So 1 week you give them vitamin C so that their pH remains acidic. The next week you can give them, Alka-Citral or something so that it becomes alkaline. So that is also one way of not giving antibiotics but keeping the urine sterile. Thank you.
Thank you, Dr. Manjula. This is a very good suggestion. So let us take the second case. The surgeon has decided to perform NDVH for a patient
presenting with multiple fibroid, and the size of the uterus is 14 to 16 weeks. So, Dr. Jyoti, what is the preoperative evaluation which you will like to do in this case to avoid major bleeding?
Yeah, thank you so much. Thank you, Dr. Meenakshi. Actually, just not for the major bleeding, I would consider, but otherwise also as such, since it is a very big size uterus, it is 14 to 16 week size uterus. So I have to make sure I have to take a good, proper history, her obstetric history, whether there were vaginal deliveries, it was a cesarean, or and whether what is her BMI, the obesity, any morbidities, because I have to be a wonderful and a very competent surgeon to do NDVH of a 16-week uterus. Also, I have to take a very good consent, explain to the patient that I will be needing blood. So I have to secure blood in the blood bank or keep the blood in the OT. And also I have to talk to them about converting it anytime. Maybe I may convert it into a TLH or a laparoscopy or a abdominal hysterectomy, considering the difficulties if I encounter, if it is a previous cesarean, if there is any scarred uterus, scarred bladder or anything. And also pre-op, definitely a complete hemogram needs to be done, and her anemia needs to be corrected and appropriately. I mean, I cannot, if I have to be very sort of I have to be ready to convert it into a open surgery anytime and not continue doing NDVH. So these are some of the points that I would keep in my mind.
Dr. Jyoti, very nicely you have elaborated. So the next question is for Dr. Anita. Which patients are at more risk of excessive bleeding during NDVH?
Thank you for that question, ma'am. The patients who are more likely to bleed, we are talking about NDVH. Of course, NDVH is fraught with more danger than decent hysterectomies. And then a patient who has earlier had pelvic inflammatory disease or is having associated endometriosis or adenomyosis for that matter, these uteri are more likely to bleed. Fibroid uterus, especially broad ligament fibroids or cervical fibroids, while enucleation itself for debulking, they may start bleeding. Then obese patients, of course, hemorrhage becomes very difficult in them to control. A patient who is on anticoagulant and her coagulation profile is deranged. Of course, we have to be very, very careful in these patients. They have to, their INR should be stabilized before we are, doing surgery on them. So previous history of any coagulopathies also makes us alert. Then, of course, surgical expertise is also very, very relevant. And you should have a good assistant. Otherwise, it will be difficult for us to control hemorrhage when we encounter that. So these are some of the...
For a very large uterus, we need to have an experienced surgeon. Dr. Aarti, what precautions will you take while performing surgery to avoid undue hemorrhage? Dr.
Yeah.
Aarti, Nisha is there?
So, what precautions to be taken if it starts bleeding?
To avoid bleeding. No, to avoid bleeding.
Yeah. Am I audible now?
Yeah, definitely.
Yeah. So if it starts bleeding, first of all,
we want you to tell us the precautions to avoid bleeding.
Okay, what precautions? All right. Okay. So, first of all, I like to put dilute vasopressin if the patient is normotensive, or just normal saline for easy separation of planes in most of my cases of NDVH, because this really helps. That is my first, you can say that is my way of avoiding bleeding. We can call it a precaution. So once all the planes are nicely separated, the chances of bleeding are less. Number one. Number two, until unless we open the anterior pouch nicely and retract the bladder up, and the posterior pouch nicely opened and retract the rectum posteriorly, don't start applying the clamps.
in most of the situations. But if you are not able to open it, of course, we have to apply clamps on Macken rods and uterosacral. Number two, the clamps have to be very good. We should not be having old loose clamps that you apply the clamp and the clamp slips and the surgeon is panicking. Oh, retract kar gaya, now again get a clamp. So be very careful in applying secure clamps. The needle holder has to be good, and although it's a very simple trick, but for my younger friends, always hold the needle little oblique on the needle holder so that you can take it through the clamp nicely. If you will hold the needle at 90 degrees to the needle holder, you will not be able to take a stitch. So hold the needle oblique and then hold it little ahead of the eye of the needle and then take a nice transfix stitch. But nowadays what I am doing, first I put the clamp, I cut it with the monopolar, coagulate it nicely, and then I quickly transfix it also. It's double the assurance that you are not leaving an oozing article. And of course, good assistants, they make your surgery successful and uneventful. Very, very important to have good assistants, proper light, and a good suction also, so that if it starts bleeding, then the surgeon is not panicking that, oh, get the suction, I can't see anything. So proper suction, proper retraction, proper light, if any of the pedicle slips. And one more thing which I would like to specify is a good modified lithotomy position. Whenever we are doing NDBH, the patient's buttocks should be beyond the edge of the table. There should be a nice cut in the table and the legs should be nicely separated, and both your assistants should be able to adjust nicely to show you and to assist you. And if it starts bleeding, don't hesitate in asking one more person to get washed and come from the abdominal side using a stool. Lot of times the older surgeons used to, I am from Dr. Sarkar's unit, who was a very famous surgeon in Agra, Dr. Barun Sarkar and Dr. Arun Nagrat. And they used to be doing NDVH in total 50 minutes. But Dr. Sarkar, he used to make sure that one stool on the side and then one person has to retract the bladder from the pubic symphysis side so that there is adequate retraction, and the surgery used to be super fast, very good light. So these small tips, they really help us. Yes. And of course, whatever is written here is good. Vessel sealing devices are also very good. Cautery is very good. We have to use the best of everything, including the best of assistants and the best of anesthetists to get the most perfect outcome.
Yeah, thank you. Can I add something, Meenakshi? Dr. Meenakshi? Dr. Meenakshi, can I say something?
Mitra ma'am, yes, and Manju ma'am also wants to add.
Dr. Aarti, you have said things very beautifully. Two very important things that I would like to say is that whenever we are doing a bigger size uterus, we know what the principle that we are applying is that we are going to be debulking it. So after the uterines are secured, we always bisect the uterus, do a myomectomy and take it out and all that. So one thing I would like to say, that if it's a single fibroid sitting on the fundus, it becomes very difficult to pull it down. So we have to know the anatomy of the fibroids that are there and so that we know really how to shell them out. Secondly is that when you are clamping the uterines, I have seen what we do is previously we were very afraid. So हम ना pedicle को free नहीं करते थे. But we take a good bite of the pedicle and we free the toe and then push the uterus back inside so that we can see our clamp and then we secure it. So just like you said that twist needle को टेढ़ा करके लेते हैं, that is a very good learning point. I have also learned that. Secondly is कि uterus को cushion कर दो, pedicle को देखने दो and then take it very securely. And once you secure your uterines of both the sides, any size of uterus you can debulk. Thank you.
Assistant should show the tip of the clamp you are going to transfix it.
Absolutely.
If the assistant is able to show you the tip of the clamp you have applied, you will never miss proper transfixion. Somebody has asked whether to transfix uterine. It is usually avoided, but if you think that the pedicle is quite thick, you can always transfix, ensuring that you are not taking the vessel. You're not puncturing the vessel. It's not
In
a
any
rule
case,
that.
it's never a free tie. Even the uterine is
No,
never
no.
a free tie. You have to anchor it, and you have to make sure that the
Yeah.
And
Can
it
I
was
add on,
already
Dr. Manju?
highlighted that the next clamp has to be medial to the previous one. And please do not ignore the interposing tissue. Our teachers used to tell us that it should override the tissue you have already cut, so that you do not
I think
leave
in
any.
case of very big uteruses, we should be prepared from beginning itself. Just when we are starting the patient, I think it is better to have some tranexamic acid to be given to the patient that takes care of the small oozings. And then the principle is that exposure should be very good. So what I do for the exposure, I take labial stitches little higher up, so that it gets quite wider away and visibility is better. So then third thing is the adequate planes. If any time you are in the wrong plane, definitely bleeding is going to be more. And then for the exposure, as Dr. Aarti, very well, we are also doing the same thing. One person is standing on the pubic side so that the overcounting of the assistant is not there. So always proceed with the posterior pouch if you're not, the anterior pouch is not visible. Then again, when you're taking the clamps, pedicles, so always take the suture beyond the tip of the clamp. Because once it is beyond the tip, small tissue in between may be there. And if space is there, you may do the doubly clamping, but most of the time the space is not so much and we have to apply only single clamp. So double clamping possible, you can do the double clamping and proceed further.
Can we ask Dr. Manjupuri ma'am to give her opinion, please? Ma'am has raised her hand.
Above that, and then you do the tie. Otherwise, single clamp we have to do with this. And if vascular part you think you can take the vasopressin, ADR, these straps are taken to take care of these small bleedings. And exposure, these are very important, which has to be taken care. Beyond the tip of the clamp, the suture is to be taken.
Ma'am wants to say. Manju ma'am, please.
So just, I think excellent points made, and
ma'am, you're muted.
No, I think I'm
No,
there.
no, you are audible, ma'am.
Yeah. So I think Aarti had made all the practical points. Just a small point which I want to add is when you introduce the needle, please do it at right angles. Normally you put it a little oblique. So you should go beyond the tip and at right angle so that it goes directly down. Sometimes you just make it a little, curved so that part of the tissue remains, and put it down and then make a full circle when you remove it. So I think that is what is important when you pass the sutures. Thank you so much.
मैम असिस्टेंट की ही कला है कैसे क्लैम्प को दिखाएगा ताकि जो सर्जन है वो अच्छे से उसको
No, that is right. And putting a suction cannula and pushing the uterus away and seeing the tip above and down below helps. So that
the other side assistant, very right, ma'am. The other side assistant should keep the uterus away so that the surgeon has some space to.
No, sometimes, Anita, the bulk of the uterus comes down. So even if they pull it, it tends to fall back. So there, if you have a suction cannula and it is just below the tip, and push the uterine body a little that side and pass the needle holding it a little oblique, like Dr. Aarti said, and pass it from above downward straight. And then make a curve and bring it out, and that is the perfect passage of suture. It never hits the clamp.
Uterus inside. You can see the clamp.
Okay. So thank you everyone. Dr. Vani is there?
Yes, ma'am.
So while doing NDVH,
there was excessive bleeding suddenly. How will you proceed, Dr. Vani?
If we encounter excessive bleeding while doing NDVH, the foremost is the proper visualization. That the assistant should retract and proper OT light should be focused on the operative area. We should suction and remove the clots, and we should locate the pedicle. Bleeding pedicle should be located after doing the suctioning. If we have adequate space of applying the second clamp, then we should reclamp, or otherwise we can take the additional sutures. What we do in the applying, if we don't have the space, we can simply apply Ellis forceps at the loose tissue, and we can religate that pedicle so as to control the bleeding. Here comes the role of assistance and the proper visualization of the bleeding point. So we should remain calm and we should not panic. We should arrange for blood and try to secure the bleeding.
Thank you, Dr. Vani. Dr. Krishna, what if the source of bleeding is unclear? You are not able to see the exact source of bleeding.
Yeah, I think everyone has beautifully highlighted all these steps, how to take the needle, how to... Basically, it is the assistant's role, is mainly the assistant's role to show the pedicles. And if bleeding is not clear, always stay calm. Ask the anesthetist that arrange for the assistant to arrange for the blood, make the patient hemodynamically stable, and then pack for a while and wait, and then take a suction in hand, and then assess all the pedicles starting from below upwards and see which pedicle is bleeding. If we can see any bleeder, catch hold with Ali's apply to the pedicle and then religate it. And if any bleeding vessel is not seen, then don't clamp anything blindly, because otherwise we can injure the bladder or sometimes even rectum, ureter, all these can be injured. So blind suturing should be avoided. And only if we can see the pedicle, if nothing is seen, then we should reinforce all the pedicles again and see whether the bleeding stops or not, and wait for the stoppage of the bleeding, pack for some time, and then reinforce all the pedicles and again see that mostly the bleeding will stop, because sometimes it is a venous ooze is there. Simply by applying pressure and again taking the sutures, the bleeding will stop automatically. But still, if it does not stop, then we have to do sometimes the pedicle retract back, and then sometime even laparotomy we have to do to control the bleeding, or there is a broad ligament hematoma is there. Sometimes even laparotomy is required. Otherwise, mostly we are able to control with reinforcing the sutures. We are able to control the bleeding. I have never opened the abdomen while doing the vaginal just to control the bleeding.
Actually, we are talking of a big fibroid actually, and multiple fibroids. So sometimes if it is broad, then uterines might actually retract back.
Sometimes
so
they
Dr.
retract.
Monica, Dr. Monica, how will you manage uterine artery bleeding? Dr. Monica, you are there?
Yes, ma'am. Yes, ma'am, I'm there.
Yeah.
So uterine artery bleeding is the commonest cause of heavy bleeding in NDVH. So if there's bleeding from the uterine artery, we should first compress that area, clean that area, clearly visualize, then check whether ligature is slipped. It can be due to slipping of ligature. Then we have to reinforce the pedicle, religate the pedicle again and secure the uterine artery.
Thank you.
So Dr. Jyoti Malik, please, when will you convert the patient to abdominal or laparoscopic approach?
Like Dr. Krishna has already said one point, that if bleeding point is not visible, that you might have to take the help of laparoscopy. Dr. Jyoti, so when we would like to take the help of laparoscopy.
Yeah, I think if everything has been done, we have seen, we have used pressures, we have taken a proper we have exposed the area very well. We have a proper light. The assistants have done their role. We have tried to see the pedicles and done the ligature part. But still, if we are not able to control bleeding, then is the time to convert this patient into either an abdominal or a laparoscopic approach. Also, again, if there is any broad ligament hematoma, if it is forming, which we cannot control vaginally, that is another issue where we should be going again to the conversion part. And if it is a difficult, we are not able to even maybe open the pouches, or if it is severely, if it is a frozen pelvis and we cannot proceed, we cannot open it, maybe as Dr. Aarti was suggesting, that she could not, if it was a very densely ventrofixed uterus or a retrofixed uterus, then also it is always safer to convert the patient rather than just trying harder and to prove yourself. I think those are the cases. And otherwise, if we are suspecting any ureteric injury or a bladder injury near the ureteric orifices, a trigonic injury near the ureteric orifices, those it would be always good to approach by a abdominal approach rather than a vaginal approach. So these are the, I think, some of the points, some of the issues where one should not hesitate to convert into a laparoscopic or a open laparotomy.
Exactly, Dr. Jyoti. So like a laparoscopic surgeon, they say LAVH, laparoscopic assisted vaginal. We, the vaginal surgeons, they say vaginal assisted laparoscopic strategy.
Approach. Right.
So we have put the clamp in the uterines from below. Then we find that there are lots of adhesion or something is just holding the uterus back. Then we can put the scope inside. There might be adhesions and all those things which you have already told us. So we should always, and I think Dr. Manju has earlier said, a prior consent of laparoscopy and even laparotomy has to be taken whenever we are doing a vaginal surgery.
So next question is for Dr. Aarti. How will you monitor such a patient who has bled heavily during surgery?
It's a very good question. I would like to share just one incident. There was a live surgery workshop going on in Dehradun, and one of the eminent surgeons, he did NDVH for 24 weeks uterus. The patient was shifted to the ward. The patient kept saying, "I'm having lot of pain." She was looking pale and she had tachycardia. Her pulse rate was 120. Her BP was 90/60. So the team was coming to the OT and telling the operating faculty, "Sir, the patient looks slow." So, no, your patient was anemic beforehand, but the tachycardia is persisting. There's no vaginal bleeding. Abdominal distension is not there, but the patient is tender, tachycardia, hypotension. So, we suggested let's quickly do one ultrasound, and patient was taken to the ultrasound room, and there was collection in the pelvis, which confirmed that this patient is bleeding inside, and this patient was shifted to the OT again, and then all the pedicles were explored, and thankfully one of the pedicle was oozing because this non-descent vaginal hysterectomy was done for a very large uterus. So the pedicles were explored from below and resutured again, and just to be doubly sure, we put in a laparoscope and checked inside that everything was clear. And then later this patient received 4 units of packed red blood cells and FFPs, but she was saved. So one has to be very alert and one has to monitor carefully after any regular NDVH or any heroic surgery, that the patient should not get anemic, hypotensive, she should not have tachycardia. And if any doubt, quickly take the patient for ultrasound. Just don't leave the patient on duty nurses. That's what
patient not looking well on second or third day is another.
Immediate post-op, Dr. Anita, within 2 hours. Because it was
So very nicely, Dr. Aarti, actually you have told us how to look for the bleeding and also how to manage it. So now time is running short. Quickly, we had a third case, but I will just quickly flip it. So the lady, she had come after 2 weeks of surgery and she had fever and mixed discharge per vaginum. She was given antibiotic but of no rescue. So now on per vaginal examination, there was tender fluctuant bulge on the vaginal wall. So Dr. Anita, what will you do? How will you proceed with this case?
Yeah. So
very short.
Ma'am. Patient has come again to you. Most likely, she is likely to have a diagnosis of some collection in the pelvis. So we'll quickly admit her, do her investigations. Basic investigations are done. Cultures are sent, like urine and vaginal discharge and culture. Now we go on to doing her ultrasound. We want to know how much collection is there and what is the nature of the collection. Are there any internal septations or not, which can suggest some amount of septic hematoma, something like that. And then you have to measure the size also. It will depend on the size, how you are going to further manage. If it's a very large or a abscess is suspected, or you feel that the retroperitoneal extension is there, sometimes you are likely to ask the patient to undergo CT scan also. So it will depend on the amount of collection the patient has.
Yeah, thank you, Dr. Neeta. So the next question is for Dr. Krishna. Hey, ma'am, we have diagnosed a case of vault hematoma. So how will you manage this patient?
So I think we should do all the first investigations, and patient symptoms are to be seen whether she is having fever or not.
Dr. Neeta,
Whether
the
pain,
knowledge
fever,
has already
discharge for vaginal.
she has been diagnosed now.
Okay, now the hematoma is around 7 centimeter. I think the next one is around 7 centimeter hematoma. So merely the size of the hematoma is not important. Along with that, the patient, if is symptomatic, she is having fever, she is having discharge, she is having pelvic abscess. So we need active management. We should start IV fluids, broad spectrum antibiotics, send HVS for culture sensitivity, and depending upon that, we should start the antibiotic. And if it is a large one and that is causing pressure symptoms also, and if pus is there, then we have, of course, we have to drain the hematoma. So vaginal route is preferred. But if there is difficulty, then even ultrasound guided or even CT guided, we can do the drainage of the hematoma. And always put a drain at that site, and the patient will be okay after the drainage of the hematoma.
So, Dr. Varni, I think Dr. Krishna has already told, just quickly drain if the collection is higher.
If the collection is higher and not reachable, it can be drained by ultrasound route, or CT guided may take the help of a CT guided needle. And surgical exploration, open laparotomy is done in cases of persistent sepsis, or if adhesions or collections, or paralytic ileus is patient is having paralytic ileus, and if we are not able to drain it from the vaginal route, then always help can be taken from the abdominal route.
Thank you, Dr. Varni. So now I think now Dr. Manju and Dr. Savita, we should just finish this discussion with your comments, experiments, and take home messages from the experts.
Just two more things to be added. When we talked about excessive bleeding, which should be avoided. One is that while we are going up and applying clamps from below, when we come to the fundal structures, so normally we pull it up and take the whole thing in one clamp. It is always a good idea to take a clamp from above and one from below, because if you take it only from above and when you deliver it out, so some of the blood vessels can get retracted and it can give rise to a hematoma later on. And there could be bleeding from there. So it is important that the last clamp, top clamp, should always be taken in two halves and you secure both. The second is that when we are, doing that incision all around, some people tend to really free the lateral part too much. So there's a lot of bleeding between the Macken rod and the vaginal, mucosa. And after you finish your NDVH, then a lot of bleeding starts coming. Everything was okay. So to avoid that, it is important that we take care of all the bleeders and do not be very aggressive, because ultimately it is going to come back. You are going to stitch the same mucosa to the Macken rods. So that part also should be avoided. Otherwise, I think it has been a great discussion and great cases, great discussion, and very interesting. Thank you.
Thank you. Thank you, Dr. Manju. Dr. Savita?
Yes,
Savita
I
is
just
not
want
there?
to add one practical point which I am using in my cases is just taking the labial stitch little higher one. Means at the higher level about 1 centimeter vagina including. So that decrease the relative length of the vagina is decreased and visibility is increased in case of NDVH when descent is not there. And secondly, once we are taking the needles, because it is a descent is almost nil here. So when we take the needle, and sometimes it may go here and there, means it may go because we are taking above the tip of the clamp, it may go into the uterine tissue. To avoid that, we have to take it at the right angles and ask the assistant, you just keep your needle holder there only and ask the assistant to catch on the tip of the needle, and that the assistant which is in the center usually that helps the most to catch on the tip of the needle, and then you can remove your needle holder to avoid the displacing the needle here and there and to avoid all sort of the mess in case of NDVH.
Can I add one thing, Meenakshi? Your patient of hematoma, post NDVH. I had one case where patient was absolutely fine. She didn't have any ileus, but there was a collection and she had some dark blood. So when we found on ultrasound a big hematoma sitting on the wall, we actually, because she was totally not septic, but there was a collection. So we actually drained the hematoma laparoscopically. So that is also, no sepsis, but just old collected blood. So I think we have an option of laparoscopy as well. It was very simple to drain that. In fact, the nature does all the thing. It was loculated. So we just had to get it out. And that was so
No, I think
but yeah.
laparoscopy should be kept an option. It is a better option because everything is under vision, and you can always clear up, even if it is sepsis, you can clear up the pus. That is also possible.
Manju, we did it in the non-septic. So I just.
Yeah, no, but we've done it in septic also. So it is
Yeah.
quite okay. You have to be a little careful. But then if a hematoma is not expanding and the patient is not symptomatic, just counsel her that some clots will keep coming. And you can always say that this many clots will come depending on how big the hematoma is. It stops. But whenever you have a patient who has a sudden fall
we can
in
put a
hemoglobin.
drain laparoscopically.
No,
we can
we don't
drain.
we normally
You have
don't
not
put a drain.
Okay.
No,
Okay.
what happens is that, this kind of thing should be in your mind, whether there's a hematoma or not, when the hemoglobin of your patient falls suddenly. So these are the kind of patients where when you do a scan, you find a hematoma. And that hematoma would normally come out on its own, but you just have to counsel the patient and give her hematinic so that the hemoglobin is built up. If it is not expanding, you don't have to worry.
Presented after a week. She was absolutely fine, but she came with a little bit of dark bleeding.
You can just leave her alone. No, you can
but
even leave
actually,
her.
I'm telling that in that patient, we did a laparoscopic drainage. So I'm just recounting my case.
You can do anything, but I think you can even leave them alone. It comes out on its own. That is what is the
Sometimes
experience.
even, ma'am, smaller hematomas, 2 by 2 centimeter, if accidentally, we can leave them as such.
Small hematoma we can always say less than 4 or 5 centimeter. We can. So thank you everyone, Dr. Ankita. I think we are lucky to have so expert people. Dr. Ankita is there.
Yes,
Thank
ma'am.
you, ma'am, for the
Ankita.
opportunity. Thank you, ma'am, for the opportunity.
Ankita,
It
just
was a
pay your
wonderful
thanks.
session, ma'am. Yes, ma'am. I would like to express my sincere gratitude to our experts, moderators, and panelists for an engaging and enlightening discussion. Thank you to all the delegates for your active participation. We had a wonderful academic program and have gained many practical learning points that we can carry to our clinical practice. Thank you so much.
Thank you, everyone.
Bye-bye.
Bye. Thanks for sharing your time with us.
Thank you all.
Hello, Aarti.
Thank you so much. Yeah.
Really?
It was a very interesting session. Yeah. Thank you for
I
inviting me.
Dr. Mukesh Chandra.
Yeah.
So we're doing NDVH. Lots of NDVH we were doing.
I know Dr. Mukesh is coming to Dehradun on 20th, but now he wants to talk on GnRH antagonist. I should have asked him to talk on NDVH only, at least, to inspire youngsters not to do TLH. Although TLH ka apna magic hai, somehow I love doing TLH because everything is so clear and you're not in doubt. But each technique has its own role. Yeah. Thank you. Thank you so
Thank you.
much.
Bye.
Aarti is from Agra. Dr. Aarti, are you from
Yeah,
Agra?
she's
Dr.
from Agra,
Meenakshi is
but
my
now she's in
senior.
Uttarakhand.
Yeah.
She was a very
Your
brilliant
batch
student.
mates?
No, she is a junior to me.
She's my senior. Yeah.
A very brilliant girl. After Agra, she has gone to MMC, to AIMS, and now finally settled in Uttarakhand.
Uttarakhand. Yeah. Thank you. You all are invited
Thank you,
whenever
Dr.
you want to
Savita,
come.
Dr. Jyoti, Dr. Manju, Dr. Mitra, Dr. Savita,
Enjoy
Krishna, and everyone.
being a part of this. Yeah. Thank you so much. Thank you.
Thank
Bye.
you all. Thank you.
Bye-bye. Have a good evening. Bye.